Topic of the lecture today is systemic mycosis. Now, it's the second lecture on the same topic, systemic mycosis. We have one lecture already done on systemic mycosis, in which we talk about what mycosis is and what are its basic categories, and how do we define what opportunistic fungal infections are, how do we define which infections involve the systemic involvements, in which we talk about what infections involve the skin manifestations. So in case you don't understand anything in this lecture, you have to refer back to the first lecture of systemic mycosis. Now, in this lecture of systemic mycosis, we're going to talk about opportunistic fungal infections. We talked about what opportunistic fungal infections are, but if we are doing only this lecture, I'm going to revise it for you. So opportunistic fungal infections are those fungal infections which cause this fungal infection in the presence of any other pathology. It can be a chronic malignancy state, it can be a malignancy state, it can be a chronic other disease, like it can be chronic TB, it can be diabetes mellitus. All of those conditions which deprive you of your basic immunity, all of those conditions which affect your immunity and lower your immunity status will lead to opportunistic fungal infections. Now, these fungal infections are not going to be present in a patient who's immunocompetent. Why? Because they're actually our normal flora. They're present with our normal flora, but they don't act against us until our immunity is down. So what are the things that will cause our immunity to go down? It can be any autoimmune disease. It can be any chronic disease. It can be any drugs that we are taking. What drugs might that be? It will be steroid drugs. Patient who is on steroid therapy is going to get it because steroids take down your immunity level, right? It can be any patient who has been subjected to this kind of pathogen before, or it can be any patient who is suffering from chronic bacterial infection, or like pulmonary TB or abdominal TB, and it can happen in all those patients which are suffering from diabetes mellitus. So all of these are risk factors into what patients are going to get opportunistic fungal infections. So one point is clear up till now, that opportunistic fungal infections are present with our normal flora and they don't cause any pathology. Like the other fungal infections, 95% are self-limiting and they don't cause any pathology. They're asymptomatic. You won't even know the presence in the body, right? They get eliminated on their own with our immunity. But when the immunity level goes down, when due to any process, due to any pathology, our immunity level goes down, opportunistic fungal infections strike and they causes pathology. Now, what are the basic opportunistic fungal infections that we're going to talk about in this lecture? First of all, we have Fusariosis. Next one, we have trichosporonosis. And third one, we have scedosporiosis. We're going to talk about each and every one of them in detail. So first of all, let's talk about Fusariosis. Now, what's the etiology? What's the epidemiology? What's the pathogenesis? First of all, what is etiology? Etiology is what's the base? Where is it coming from? What's the causative thing? Epidemiology, where is it found? What areas are more prone to get affected because of Fusariosis? And pathogenesis, we're going to talk about how it gets into your system, how it causes this pathology. What's the mode of transmission, how it gets to your systems, and once it made entry into your system, what's the pathology it's going to cause, right? So first of all, we have to know, I just told you about that it's going to be an immunocompromised patients. Because immunocompromised patients which are suffering from any kind of disease which affect the immune system, like HIV/AIDS is one of those examples. So immunocompromised patients are at higher risk of getting this pathology. Because our immune levels are down, they don't have any resistance in causing this infection. They don't have anything to fight with. They just go in, immune systems are down, they just cause a disease, they just cause this pathology. So immunocompromised patients are at higher risk in getting this pathology. Next on, we have contact lens wearers. Why? Because most of the people do what? They just take off their contact lenses and just throw them away on the shelves. They are put upon these shelves, they are put upon these washrooms, they are put upon anywhere, they are put upon the side of the bed. No one cares a damn about that. Maybe there's a fungal infection here. Maybe there's a fungus here that we don't know about. And it will make contact with that lens. And when you will wear that lens again, you will inoculate that fungus into your body by yourself. So those people who wear contact lenses should be very careful about where they put their contact lenses after they take them off. Next on, we have hematologic malignancies, right? So the patients who are suffering from malignancy, any kind of malignancy, are already immunocompromised. They're already taking chemotherapeutic drugs. They're already taking either radiations or they went through a surgical procedure. The immunity is already down. It's actually not the malignancy that causes this immunocompromised state. It's actually what comes afterwards, these surgeries, these chemotherapies. The treatment is actually what causes this immunocompromised state. So, a patient with suffering from malignancy is already immunocompromised, and then we will start with chemotherapeutic drugs, then we will start with radiations and with surgeries. The patient's immune levels go down. And when the levels go down, what happens? They are more prone to getting this fungal disease. Now, these funguses basically may be present in your body right now, but they won't cause any infection because you're healthy, your immune levels are up to the mark, and they will be eliminated by that immune system. But if you're subjected to any one of these three processes, like if you're immunocompromised, if you're contact lens wearer, or your hematological malignancy is following you, you're going to get this disease immediately afterwards. Next, neutropenic patient. Why neutropenic patient? Neutropenic patients because what? Neutrophils are the first defense of your body. Neutrophils are the first defense against any invader in your body. Whenever any invader, any pathogen, it's bacteria, it's virus, it's fungus, neutrophils are the first to report, and they're the first in trying to eliminate the pathogen. But if there's neutropenia, if neutrophils are down, neutropenia means neutrophils, penia mean low levels. So neutropenia, low levels of neutrophils. So if the levels of neutrophils have fallen, they won't be providing you with the defense they're supposed to provide you with. So defenses will be down, neutrophils are not acting against any kind of it. So first defense of the body is down. It means you're immunocompromised. It means that you're going to get this disease. Which patients have neutropenia? Patients who are suffering from acute kind of pathology, very acute kind of pathology, or patients who are suffering from chronic pathologies. But basically, it's a patient who are suffering from chronic pathologies. They are suffering from neutropenia, and they get this pathology. Next on, we have stem cell transplant. You all know what happens in stem cell transplant. Stem cell transplant means that when you have to remove and then do the stem cell transplant, what do? You give the patient high steroidal dose and immunomodulator drugs so that this body does not reject the stem cell. To avoid the rejection, you give high steroid drugs and immunomodulator drugs. So that takes an immunity down to zero actually. And when your immunity is down to zero, you are going to get Fusariosis because you're immunocompromised. They don't have to fight against any kind of wall, any kind of barrier. Your first defense of the body is neutrophil, they're down. Your second defense of the body is phagocytes, they're down. So they don't have to even fight anything to cause infection. So they're going to definitely cause infection in the patients who went through stem cell transplant. Next on, we have solid organ transplant. Just like stem cell transplant, in solid organ transplant, when we prepare a patient for solid organ transplant, say it's liver transplant, when we prepare a patient that you were supposed to go under liver transplant, we change the whole regime of the patient. We change the whole pattern of even eating, sleeping, everything, we change it. right? And after this solid organ transplant, what we do is we give high steroid therapies and immunomodulator drugs so that this organ won't get rejected. So it's the same mechanism. We give these drugs, we give these steroids, but they take our immune system down because that's the goal of this therapy. We have to take our immune system down so that it won't kill its own cells, it won't kill the new organ, it won't kill the transplanted organ. So immune system is down, and this causes infection. This causes fungal infection very easily because there's nothing to fight, there's nothing to protest against, or there's nothing to cross as a barrier. So they cause fungal infections. Next on we have severe burns. What happens in severe burns? Your skin is removed actually. Your skin is removed. You are subjected to any kind of pathogen. You are subjected to pathogen which are present outside. So any fungus or any mold can get in contact with those areas and cause infection. And on the other hand, when you are suffering from severe burns, your immunity also goes down, so it can cause systemic manifestation as well. So both of these can happen. Now, what's the epidemiology? One thing to ponder here, what is epidemiology? Now, epidemiology is not specific in this case because it can be found anywhere. These are molds, fungus, they're found everywhere. So if they're found everywhere, what kind of epidemiology you will look for? We'll look for all those people who are immunocompromised, who are contact lens wearers, who are carrying a malignancy, who are neutropenic, who are stem cell transplant, who went under solid organ transplant, who went under severe burns. All of these patients are at risk, and they can be anywhere. It's not like they have to be in one area, they have to be in underdeveloped countries. They can also be in developed countries. They can also develop all these infections in developed countries. Now, what's the pathogenesis? The pathogenesis is the same as we talked about in Systemic Mycoses Lecture 1, that once this fungus which is present on the soil or plants or wherever its origin is, these hyphae produce conidia. Conidia are round cells which are airborne, right? When they're airborne, they get their entry through our nares, they go into our respiratory system and cause the pathology there. If the patient is not immunocompromised, if the patient is immunocompromised, it's going to cross that barrier, it's going to go into hematogenous spread, it's going to go into lymphogenic tissues and organs, and it's going to go into reticuloendothelial system and cause the pathologies there. So that's going to be the pathogenesis of it, right? So now let's talk about the clinical manifestations. What clinical manifestations will it present with? First of all, the hashtag, you should say it's a hashtag, immunocompromised patients. So in immunocompromised patients, what you get is fungal keratitis. Fungal keratitis is eye infection. It is caused by fungus. Fungal keratitis in anterior chamber of the eye, as well as it will lead to loss of vision. It will lead to corneal transplantation. See, it has very severe consequences. And it happens in those patients which wear contact lenses. We talked about they are at higher risk of getting this pathology. So they'll get fungal keratitis, which will lead to which will be affecting anterior chamber of the eye. And once it affects the anterior chamber of the eye, what happens? Loss of vision will happen. And in the loss of vision, corneal transplantation will be required. Next on, we have onychomycosis. Now, what is onychomycosis, first of all? Onychomycosis is actually infection of your nails. Your nail beds, your nails is called onychomycosis. Now, this happens in those patients which are neutropenic patients, as well as in which hematogenous dissemination has happened. It means immunocompromised patients. We talked about hematogenous spread won't be carried out if the immunity level of the patient is up to the bar, if immunity level of the patient is normal. Next on, we have a condition which mimic actually aspergillosis and its manifestations. Now, what happens in those patients is Fusariosis, angioinvasive. Angioinvasive means it invades your blood. It invades your blood vessels. With patients, in immunocompromised patients. And other patients it won't. So Fusariosis is angioinvasive. It invades your blood supply. It invades your vessels. Next on, we have pulmonary infections. Now, pulmonary infections happen in those patients which are immunocompetent, which are above the age of 60. They are not suffering from any immunocompromised state. They're not suffering from any chronic disease. But due to it, their immunity levels are down, but they're not that down that this will cause dissemination. These infections will only lead to pulmonary infections at most in those people. So in pulmonary infection, what we'll see is multiple nodular invasions. Next on, we have sinus infections. And in sinus infections, we will have what? Invasion of the adjacent structures. Now, these are all the involvements in immunocompromised patients. If it affects your eyes, it's going to be affecting the anterior chamber of the eye. It's going to affect and cause loss of vision and will lead to corneal transplantation. And onychomycosis will be happening in those patients which are immunocompromised, have hematogenous spread, and next one are neutropenic. Aspergillosis manifestations will come through because they invade your blood vessels. They're angioinvasive in nature. Pulmonary infections will be seen in those patients. There will be multiple nodular invasions, and sinus infections are very rare, but they do happen in patients suffering from Fusariosis. How do we diagnose Fusariosis? What's the diagnostic modality that we use in diagnosing the Fusariosis? First of all, you go for the histopathological techniques. Now, let me take it back. Before we go on to histopathological techniques, how will we know that it's Fusariosis? Let's go for the histopathological techniques. No, that's not the pattern. That's not the pattern recommended. You'll go for the basic tests before. You'll go for the CBC, you'll go for the LFTs, RFTs, you'll go for the urine testing. First of all, you'll exclude everything else which might cause this pathology, right? Once you're sure that, okay, it's systemic involvement and it's because of a fungi, then you'll go for these diagnostic modalities, which will involve histopathological techniques in which septate hyphae in tissue will be found. Next on, it's difficult to differentiate from Aspergillus species, so you'll go for the blood culture. Next on, we have fungal reference labs present, and we'll go for the PCR. Now, these three are the basic modalities that we use to identify and diagnose fungal infections like Fusariosis. You go either for histopathological techniques, but in those histopathological techniques, what we'll see is septate hyphae. In blood cultures, you will go for blood cultures, you will get the report, but it's very difficult to differentiate it from aspergillosis. That's why we talked about it. It mimics aspergillosis. It not only mimics aspergillosis in clinical manifestations, but in cultures as well. And next on, you'll go for the PCR. What's treatment of choice for Fusariosis? You don't have to memorize every treatment I tell you. It's just a matter of concept. It's Fusariosis, it's a fungal infection. What you'll go for? First of all, amphotericin B. All you have to remember are the doses. In this pathology, we give it 5 milligram, and then we have voriconazole, which is 200 to 400 milligram. Now, these are the treatments which are recommended for treating Fusariosis. We can give postconazole if a patient is somehow sensitive to voriconazole, right? Otherwise, amphotericin B and voriconazole are the first line of treatment against this pathology. Next on, we have scedosporiosis. Now, scedosporiosis is caused in the temperate climates. Now, we talked about the epidemiology of Fusariosis, right? And we said it can be found anywhere because the people being affected can be found anywhere. But in scedosporiosis, what you see is it happens in most of the temperate climates, not everywhere. It mostly happens in temperate climates. It can happen everywhere, but most of the times it's happening in temperate climates. Next on, it will lead to pneumonia. Now, pneumonia, what does that indicate? It indicates the entry of this organism. They entered, they cause pulmonary infection, because they went into the lungs, they cause pulmonary infection. Now, if you're immunocompromised at some level, they're going to disseminate into your blood. This will lead to disseminated infection. So this will disseminate into your blood, and then it might cause brain abscesses in the patients which are suffering from immunocompromised state. Brain abscesses are seen. Now we're talking about the epidemiology, right? We've talked about etiology, we've talked about epidemiology, now we're talking about pathogenesis. How does it happen? We inhale conidia, it's the same pathogenesis all along. Those hyphae produce circular structures called conidia. We inhaled them, they got into our lungs, they caused pneumonia here, they disseminated, they affected the brain, caused the abscesses, and they can infect the other lymphogenic structures, they can infect the other organs, basically reticuloendothelial system. Or they can inoculate directly through the skin. If there's a break in your skin, if this patient is subjected to burns or something like that, they can inoculate through your skin and cause skin manifestations or cutaneous and subcutaneous infections of fungal origin. Or inoculation of the eye, we talked about it. Contact lens wearers most of the times get it. They can inoculate your eye. They can lead to what? They can lead to anterior chamber involvement. They can lead to blindness, and then corneal transplantation is required. Now, these are the etiologies, epidemiologies, and pathogenesis of scedosporiosis. How do we diagnose scedosporiosis? We diagnose scedosporiosis. First of all, you'll go for all those basic testing we talked about. We exclude everything else. Then only thing we have in our mind is fungal infection. Now we'll go for what? We'll go for the histopathological techniques, in which we'll see what? We'll show septate hyphae in the tissue. Next on, we'll go for the culture evidence, in which we'll find what? Scedosporium species are difficult to differentiate from Aspergillus. It's the same diagnostic modality, it's the same results we talked about in Fusariosis, right? So next on, we'll go for what? We'll go for the demonstration of the tissue invasion. And that's where it gets tricky, that ubiquitous environmental molds can be contaminants or colonizers, right? So you won't get even definite answer then. So after doing all this testing, you'll get this idea that okay, this means that it's a fungal infection. Nonetheless, then you can either treat the fungal infection by giving the antifungals, knowing that it will treat it somehow, or you can go for the further testing like PCRs. Next one, we'll go for the blood cultures. In blood cultures, Streptococcus proliferans grows in blood culture and causes Streptococcus apospirumum. Now, this is a definite diagnosis for you. I know it takes time for blood culture to happen, but you have to go for it eventually, because you can see septate hyphae was shown in the tissue in the Fusariosis as well. Now, it was difficult to differentiate from Aspergillus in Fusariosis as well. And this ubiquitous environment molds can infect. So you will definitely go for the blood cultures, and you'll get this results coming in, and you'll know definitely what's the cause of this. And at the end, we'll go for the PCR techniques. In PCR techniques, we definitely know what's the basic organism that's causing this pathology. And fungal reference laboratories are available, which will confirm your diagnosis. Once you know the diagnosis, what you do? You go for the treatment. What treatment modalities we have? We have voriconazole, we have postconazole, we have terbinafine, and we have conazole. So these four are first line of treatment against scedosporiosis. I hope you remember them. First two drugs are the same that we used in Fusariosis. Other two drugs are different from the Fusariosis treatment, and they're different because if a patient has somehow developed a resistance against sensitivity and resistance against voriconazole and postconazole, we can also give terbinafine and conazole. Next on, we have trichosporonosis. Now, etiologies, epidemiologies, and pathogenesis of trichosporonosis. First of all, it's found in where? In the water, in the contaminated water, in the wastewater. Next on, in the plants, in the soil, in the standing water. So, source of infection or the presence of these funguses are the same. They're found in water, contaminated water, standing water, plants, and soil. So, root cause is the same. From where it's coming is the same. Where does it infect? Infections caused are pulmonary infections, or they can get through your nares and cause pulmonary infections. They can get through an IV line and cause infection, and they can infect your GI systems, right? When you ingest such things. Now it's very rare. GIT involvement is very rare, but most oftenly we have this respiratory involvement. Less oftenly we have IV involvement, and very rarely we have GI involvement. Now, GI involvement will be happening if you consume that mold. Now, that's very rare. If you look at a food and you see fungus growing on it, you won't eat it. Unless you eat it, you won't get GI manifestations, you won't get GI involvement. So, only way to get this pathology in your GI system is if you ingest such a thing which has hyphae on it or fungus on it. Next on, which people are at risk? You can close your eyes and tell me the answer. They are going to be immunocompromised patients like HIV/AIDS. They're going to be hematological malignancy patients, and they're going to be what? Steroid consumers. We talked about them, all of them in detail, that these malignancies will take your immune system down, and then you go for the chemotherapies, the radiotherapies. They'll take your immune system further down, and you make that patient prone to this infection. Next, we have steroid therapy. In steroid therapy, your immune system goes down. You're actually giving high steroid drugs to those patients who are undergoing organ transplantation, stem cell transplantation, so that the body won't reject them. But in order to do that, our immune system is taken down. When the immune system is taken down you are actually making your body prone to such infections, because these are actually opportunistic infections, and when the immunity goes down, they strike. So how do we diagnose it? Diagnosis will be through same modalities. You go for the histopathological techniques. You go for the histopathological examination of skin lesions, and will form yeast forms and arthroconidia and hyphae. They'll confirm your diagnosis. Next one, you'll go for the serum, in which you'll look for cryptococcal antigen latex agglutination. It's a new test which is available in different laboratories, which confirm your diagnosis in a very short time, so that you can start the treatment for it. Next one, if the test is positive, you are sure that it's trichosporonosis. What's the clinical manifestation it will present with? If it's disseminated, right? If it's disseminated, or if it's chronic. Now, the clinical manifestation of the patient in which it's disseminated are going to be far different from the patient in which it's chronic. Now, let's compare them. What clinical manifestations will a patient which is suffering from this disease in a disseminated state will present with, and what are the clinical symptoms and clinical manifestations a chronic patient will present with? First of all, in disseminated patient, invasive candidiasis will happen, fungemia will happen. Now, what is fungemia? You know about invasive candidiasis, but what is fungemia? Fungemia is presence of fungus in your blood. That's what fungemia is. It means it went into dissemination. So fungemia will be found, pneumonia will be found, skin lesions will be found, and sepsis syndrome will be found. Now, these 5 are the clinical manifestations if it goes disseminated. It means invasive candidiasis will be coming on, the presence of fungus in the blood will be seen, patient will be suffering from pneumonia, patient will have all these symptoms of pneumonia, patient will be suffering from chronic pneumonia or acute pneumonia. It can depend upon the immunity level of the patient and different categories of the patient, like if the patient is of old age or young age, you can find skin lesions on those patients, and you can have this sepsis syndrome in which the patient will be going under sepsis because of fungemia. Next on, in chronic patient, you will have this whole clinical manifestations. You will have this syndrome-like appearance. You will have this structure. You will have these symptoms which will mimic actually hepatosplenic involvement, that only liver and spleen are being involved. Why? Because it affects reticuloendothelial system. So they are at higher risk of getting involved, and it mimics their involvement, hepatosplenic involvement. Next on, what's the treatment of trichosporonosis? You start with voriconazole with 200 to 400 milligram twice daily, and that's all. That's all you have to remember for trichosporonosis. Now let's talk about superficial cutaneous infections. In the first lecture of systemic mycosis, we talked about that it can be superficial cutaneous infection, it can be systemic involvement, it can be opportunistic fungal infection. So now we're talking about superficial cutaneous infections. Those infections which are superficial involve the cutaneous layers of the skin and cause infection. Now subcategories involve either it's going to be a yeast infection or dermatophyte or mold infection. Before we move on to what yeast infections are, what its clinical manifestations, what mold infections are, what are its clinical manifestations, first let's talk about why it's converting. In the first lecture, we talked about most of these organisms are what? They can convert from mold to yeast. It actually depends upon the temperature. Some of them are mold at 25 degrees centigrade, but at body temperature, they're yeast. Most of the conidia that we inhale actually are molds converted to conidia, but in the body temperature, in the pulmonary temperature, they convert into yeast. But as now we're talking about skin manifestation, most of these infections will be coming from mold because we get in contact with mold more oftenly. So we have these yeast infections and we have this dermatophyte or mold infection. Now let's talk about them. First of all, let's talk about the yeast infection. What's the etiology, epidemiology, and pathogenesis? Now this is a person. Now where will yeast infection strike? Lipophilic yeast lives on skin, right? It lives on skin because they're going to involve what? They're going to involve your cutaneous layers. Now, lipophilic yeast means the other yeast lives in your pulmonary system. Most of the yeasts live in your pulmonary systems, involve your pulmonary systems. So they don't come out of the pulmonary system and causes pathology. Only a specific category of yeast, which is lipophilic in nature, is going to live on your skin. So what will happen? They transform to disease-causing mold phase. I told you they can change. They can change from yeast to mold due to different temperatures, due to different temperate climates. They can change into mold and causes disease. You can see the involvement of the whole chest here. So what does it involve? It involves the stratum corneum. At the scalp, at the face, at the back, at the chest. Now these are the involvements which it carries with itself. These are the involvements of the stratum corneum at different places which get involved during a yeast infection. So what are the clinical manifestations? First of all, we'll have tinea versicolor. This will be involving, you can see these white patches present and whole skin involvement and redness and whiteness and patches present. This is tinea versicolor. Next on, you have this truncal involvement, which is called folliculitis. Next on, you have this seborrheic dermatitis. You can see seborrheic dermatitis here. Now, these are the clinical manifestations of the yeast involvement. If yeast is involved, if yeast is causing this infection, we talked about it's affecting what? It affects your scalp, it affects your face, it affects your abdomen, it affects your back as well. So all of these will have different manifestations. Maybe the patient will have all of these three conditions in common, or all of these three conditions at once, because these are the yeast manifestations. So these are the clinical manifestations that yeast will present to you with. How do you diagnose the patient? First of all, you will go for the budding yeast. You'll find the budding yeast. Now, diagnostic modality for confirming the yeast infection is to scrape that space and see it under the microscope. And if it's budding, budding is a characteristic of yeast, and you will be sure of your diagnosis. and you will see these short septate hyphae. When they are budding, one of them is larger than the other one is shorter. And when you look at it under a microscope, you'll see the budding and you'll see this short septate hyphae. So you'll know your diagnosis to be of sure nature. What's the treatment of yeast infection? You'll start with selenium sulfide shampoo because it's skin manifestations. It's causing all these pathologies of the skin, seborrheic dermatitis, and all the other pathologies we talked about. So you will start with selenium sulfide shampoo. Why shampoo? Because of the involvement of the scalp when use the shampoo. Next on we have ketoconazole shampoo. Next on we have terbinafine cream, which will be used alongside the body where it's affecting, and even in those areas which are not yet affected. And next on we have cyclopyrox cream, which can also be used in the yeast infection. Now these are the treatment modalities which we use if yeast infections occur, and it involves the clinical and it involves your skin and cutaneous layers. So what happens is that superficial cutaneous involvement of the yeast is caused by lipophilic kind of yeast, and the treatment is of these four basic drugs. You can give shampoos for the scalp involvement and creams for the whole body which is being affected and which is not yet being affected. Next on we have dermatophyte or mold infection. We talked about either it's a yield infection of the skin or either it's a mold infection of the skin. We talked about yeast infection, it's on the side. Now let's talk about the mold, or what we call as dermatophyte infection. Now what's the etiology and epidemiology? Now mold infections on the other hand can go from person to person contact. If you have been in contact with such a bread, let's say, that's the most common thing you can get in contact with. Maybe you put a bread in your corner that I'll eat it tomorrow, but you forget about it, or you go on a tour and you come back and it's full of hyphae now, full of mold now, and you don't know about it. You take it out and you're like, oh my god, it's fungal now. Fungus has affected it, so I won't be able to use it, and you don't wash your hand. Or you're already suffering from this pathology and you don't know about it yet, or even you know about it and you go for a handshake, you will contaminate the other person. So that's how it goes from person to person. Next on, you have these fomites. What are fomites? Fomites are actually those things, those utensils that we use in our everyday life, and they can carry this pathogen, they can carry this mold to the other person. Let's see in this diagram, what are we talking about? Hair dryer, scissors, injections, toothpaste, toothbrush, comb. All of these things are called fomites. They are the carriers of this pathogen. They are the carriers of mold. They carry it from one person to another person, or they can carry it with itself, and when a person uses them, the mold will inoculate, the mold will get to your body and causes pathology. So that's why these things, these utensils that we use every day are called fomites. Next on, person to soil contact, we talked about the basic reservoir of these funguses is soil. So when you get in contact with the soil, you are definitely going to get in contact with fungus or mold or dermatophyte. And then further on, it depends upon your immunity levels. If your immunity levels are down, they're definitely going to cause this pathology. Next one, person to animal contact. Now, that's most likely to happen because animals don't bother about a mold. They go into the dumps and they start eating whatever they want. And if they're not vaccinated enough, if they're not taken care of, and they go on and come back and you just pet them, maybe they were in contact with the mold, and by just petting them, by just taking care of them, by just giving them a bath, you're going to get this mold on your skin. So that's how you get it from an animal. Now let's talk about the pathogenesis of it. So what happens is the spores from what? Soil, animal, man, and fomite. What are these four things? These are actually reservoirs from where these spores can bud off, these spores can come off and cause this pathology. Now they'll get into the form of dermatophyte, and then they will invade your skin. They invade or the keratin layers and skin and hair and nails. They can invade anything. That's why the involvement of scalp is there. That's why the involvement of chest is there. That's why the involvement of back and face is present in cutaneous involvement of the fungal infections. So they invade your keratin layers of skin, hair, and nails, and skin abrasions will be caused. Now, what happens afterwards? They enter the stratum corneum. We talked about that molds are going to affect the stratum corneum one way or another. But in the last slides, we talked about the yeast is only going to go until stratum corneum. They affect your scalp, they affect your back, they affect your abdomen, they affect your face, but they involve only stratum corneum. But in this, what we see is they enter stratum corneum and release the keratinases, which will lead to inflammatory reactions, and this will lead to redness, swelling, heat, and alopecia. Alopecia means a chunk of your hair at one place will be gone. Now, this can be here, this can be on the chest, this can be on the face, this can be anywhere. That's what alopecia is. So, dermatophytes are also going to go into stratum corneum. They're going to release these keratinases. And once these keratinases are released, they're going to cause inflammatory reaction, cause redness, cause swelling, heat, and afterwards, loss of hair will be coming through because of this keratin layer involvement, and you'll go into alopecia. Now, this alopecia can be anywhere. We talked about that. Now, after the inflammatory reaction, movement away from infection site. What does that mean? Meaning that if the infection site was like right here on the scalp, now it will move from this place to here and cause infection here now. Then, when it has caused infection right here, it will move from here to your chest. So they move from one point to another point. From the infected point or infection site to another site to cause further infection. They propagate. And then central healing with classical ringed sign. Now, they have caused redness, right? They have caused this heat, they've caused alopecia. Now the system will come through and they'll try to heal that place. Try to heal the infected site. And when they heal the infected site, what happens is that we get a classical ringed lesion. Classical ringed lesion on that site. That's how we know that dermatophyte infection was there. They leave a scar. Next on, what are the clinical manifestations of it? We get this tinea capitis. We talked about it. Tinea capitis will be here. And what is this? Whole bunch of hair are gone. We talked about it. Alopecia. Tinea pedis will affect your feet. It will affect your feet in this way. Joint involvement will be seen. Tinea corporis will be affecting the body. Now, tinea capitis affected the scalp. Tinea pedis affecting the feet. Tinea corporis affected the body. And you can see this ringed lesion, right? We talked about it leaves a ringed lesion. It's well circumscribed lesion. You can see it right here. Tinea corporis actually happens on the body. Now, tinea curis will be acting on the crouch. You can see this whole involvement. These are demarcated lines, tell you where it was. Next on, in the nails, we have tinea unguium, and it affects your nails, and you can see the redness here and the blackness here. It affects your nails. And so the involvement in the yeast we saw was only of skin, scalp, face, back, and abdomen. On the other hand, in the mold, we have this scalp involvement in the form of tinea capitis. We have this feet involvement in the form of tinea pedis. We have this body involvement, all over the body involvement in the form of tinea corporis. And we have this crotch involvement in the form of tinea curis. And we have this nail involvement in the form of tinea unguium. So the clinical manifestations and skin manifestations it presents to you with are of variety. So they're not like yeast that they're going to be only of scalp, skin and stuff. No, it can affect anywhere in your whole body on the outer side of it actually. Now, how do we diagnose this patient? First of all, you take the scrapings from these lesions. These lesions we talked about. These ringed lesions, these lesions on the scalp, these lesions on the feet. we take scrapings of it. When we take scrapings of it, we put it under electron microscope and we see the hyphae, the presence of hyphae. We examine these hyphae. Examination of hyphae will tell us that it's dermatophyte infection, it's mold infection. Next one, if you're not even still sure, you go for the culture testing and the culture will give you a definite diagnosis. Now, what's the treatment of dermatophyte infection? Lotions and creams we talked about in the yeast infections are also useful. You give oral itraconazole, you give oral terbinafine. Why? In the yeast infection, we were just taking lotions and creams and shampoos. There was no systemic drug whatsoever. But why are we taking it here? Because it involves most of the area of the skin and it can actually get through. So that's why we give systemic drugs, so that you don't get these alopecias, you don't get these body involvements that are unwanted. So you give systemic drugs like oral itraconazole and oral terbinafine. Now that's all for systemic mycosis and the topic of opportunistic fungal infections, which can happen, and the topic of superficial cutaneous infections that can happen because of fungus. Now, one thing you just have to know that these pathologies will be happening only in those patients which are immunocompromised, or which are going under some kind of steroid therapy, or which are going under some kind of immunomodulator drugs, or which are those patients which went under organ transplantation, or we are giving them immunomodulator drugs because they are suffering from autoimmune diseases. And most of those patients which get in contact with soil, pets, and fomites, all of those patients will get skin manifestation on the other hand. So those patients which are suffering from any kind of disease which affected their immune system should be very cautious about getting in contact with such pathogens, because they're opportunistic. Once they get into your body, you won't be able to get them out in a very easy manner. They will cause much of damage. So that's all for today. Thank you for watching sqadia.com.